Hello, today my topic is on clinical approach to vertigo. I am Dr. Rajesh, the consultant neurosurgeon from Sunshine Hospitals, Karimnagar. See, the definition of vertigo, it is given by International Classification of Vestibular Disorders. It is sensation of self-motion when no self-motion is occurring, or the sensation of distorted self-motion when during an otherwise normal head motion. And the other definition is, it is illusion of movement of self or environment due to imbalance of tonic neurological activity in the vestibulocortical pathway. The learning objectives of the topic consist of two elements. One is to understand the orientation of semicircular canals, and the other one is effect of stimulation of individual semicircular canals. First one is, we need to understand the orientation of semicircular canals. This diagram shows the orientation of semicircular canal. Generally, each ear consists of three semicircular canals, that is anterior or superior, posterior or inferior, and the horizontal or lateral semicircular canal. Its title showing the anterior, posterior, horizontal, this semicircular canal doesn't lie exactly anterior or posterior horizontal in position. There is some amount of deflection present in each semicircular canal. Example, the anterior semicircular canal lies 45 degrees outwards and 30 degrees upwards, whereas the posterior semicircular canal lies 45 degrees outwards and 30 degrees downwards, and the horizontal semicircular canal lies 30 degrees upwards. In this diagram, the patient is lying on the supine position. During this position, the horizontal semicircular canal doesn't lie in vertical position. In order to make it vertical, the head of the position has to be flexed for 30 degrees. I am discussing this to make the examination part easy to understand to the listeners. And one more finding is, I intentionally kept this image of Usain Bolt to know or to memorize or is to remind that the semicircular canal of one ear lies exactly parallel with that of semicircular canal of the other ear. Example, the anterior semicircular canal of right ear lies exactly parallel with that of posterior semicircular canal of left ear. And what are the effects of stimulation of each semicircular canal? See, the stimulation of anterior semicircular canal causes movement of eyeballs to the upward direction and rotating toward the opposite side. And the stimulation of posterior semicircular canal causes movement of eyeballs to the opposite side with downward movement, whereas stimulation of horizontal semicircular canal causes movement of eyeballs to the opposite side. See, by seeing this slide, we will get a doubt. What happens when we stimulate both anterior semicircular canals simultaneously? Clinically, it is clinically or practically it may not be possible, but if it happens, the upward direction, the eyeball will move to the upward direction. Okay, by stimulation of both the anterior semicircular canal. By stimulation of both the posterior semicircular canal causes movement of eyeballs in the downward direction. And in this slide, I want to highlight what happens to the ocular muscles by the stimulation of semicircular canal. See, the stimulation of anterior semicircular canal causes or excites ipsilateral superior rectus and contralateral inferior oblique. This causes movement of eyeball to the opposite side and in the upward direction. And what happens if the posterior semicircular canal of one ear is stimulated? It causes or excites ipsilateral superior oblique and the contralateral inferior rectus. This causes movement of eyeball to the opposite side in the downward direction. And these slides clearly shows that clinical approach or titrate method in approaching a patient with vertigo. Titrate method. It consists of three elements like timing, triggers, and examination of targeted eye movement. In timing, we need to ask the patient whether the complaint is acute or episodic or chronic. And the second method, triggers, we need to ask what are the triggers for vertigo. whether it is positional or with head motion or with sound or valsalva. There are 4 categories of disorders that present with dizziness or vertigo, and there are 2 most important histories that can differentiate true vertigo from other disorders. And the 4 categories of disorders are: first one is loss of consciousness associated with syncope or seizures, and second one is gait disorders. Gait disorders include ataxia or spasticity, or subcortical gait disorders or Parkinson disorders. All these patients, they'll complain giddiness because of imbalance while walking. And the third category is systemic disorders. Patients with anemia, hypotension, cardiac disorders, or other systemic conditions sometimes presents with dizziness. And the last category is true vertigo disorders. It includes BPPV, vestibular migraine, venous disease, vestibular neuritis, and brainstem stroke. And I just now said that there are by listing 2 histories, we can differentiate true vestibular disorders from the other categories of disorders. Among that, one history is we must ask whether there is a loss of consciousness present or not. Generally, loss of consciousness will be seen in syncope or seizures. And the second question we must ask is whether the patient is lying comfortably on the bed or not. The patients with gait disorders or systemic disorders, they generally lie very comfortable by lying in bed. And the patients with true vertigo disorders generally complains of exacerbation of complaint while lying on the bed or by turning on the bed. Among true vestibular disorders, I want to discuss a topic, BPPV, today. Learning objectives of BPPV. Learn 2 manners to diagnose the posterior canal BPPV, and the nystagmus, and what is the type of nystagmus seen in posterior canal BPPV, and what are the 2 manners used to treat posterior canal BPPV, and what are the types of horizontal canal BPPV. Before going into the objectives, I want to highlight that what is the common type of BPPV we will see in the clinical scenario. Generally, BPPV is associated with posterior canal, and the second most is horizontal canal. Generally, superior canal or anterior semicircular canal doesn't show any BPPV because of its anatomical location. Just now we have discussed that anterior semicircular canal lies 45 degrees outwards and 30 degrees upwards. Because of this position, deposition of otoconia in the superior semicircular canal is unlikely. What are the manners used to diagnose posterior canal BPPV? That is Dix-Hallpike manner and side-lying test. I want to highlight all the listeners to memorize any of the tests in eliciting posterior canal BPPV, because it prevents unnecessary confusion in clinical examination of patient. In this seminar, I am discussing both the tests. First of all, I am discussing Dix-Hallpike test. In Dix-Hallpike test, patient is made lie down from the edge of the table by hanging the head 30 degrees above and 45 degrees outwards. This causes positioning of posterior semicircular canal to lie exactly vertical, so that there will be stimulation of posterior semicircular canal of that side by movement of otoconia. By stimulation of posterior semicircular canal of the diseased side, causing movement of eyeballs to the opposite side and the downward direction, along with nystagmus presenting in the upward direction. See, here the diseased part is lying downwards, so there will be movement of eyeballs to the opposite side in the downward direction, but the nystagmus is presenting in the upward direction. There is no differential diagnosis for posterior canal BPPV. And what are the manners used to treat posterior canal BPPV? It is Epley's manner and Siemens manner. Learn any one of the technique to treat posterior canal BPPV. I am discussing both the topics. Epley's manner, it consists of 4 steps. And the first step is Dix-Halpic manner itself, is that patient is to made lying in the supine position by hanging the head from the edge of the table, by rotating the head 45 degrees outwards and extending the head 30 degrees upwards, and stay in this position for at least 1 minute. After completion of 1 minute, turn head 90 degrees to the opposite side and stay for 1 minute. After that, turn the whole body 90 degrees and lie in that position for 1 minute. After that, ask the patient to sit down for 1 minute. This causes reduction of otoconia from posterior canal and improvement of symptoms. And the second manner is Siemens manner. This manner is very easy to remember because it consists of very minimal steps, and I'm explaining each step. Ask the patient to sit on the couch and ask the patient to turn the head to one side and lying on the ipsilateral side of the shoulder for 1 minute, so that head is facing to the ceiling. In this position, patient has to stay for 1 minute. After completion of 1 minute, immediately patient has to make him to lie on the opposite side of shoulder, so that his nose should point toward the ground. This causes reduction of otoconia and improvement of symptoms. And what are the types of horizontal canal BPPV? There are two types of horizontal canal BPPV is seen. One is canal lithiasis and other one is cupulolithiasis. In canal lithiasis, patient can have geotropic kind of BPPV, where the eyeballs are moved to the opposite direction, that too in the downward direction. Whereas in the cupulolithiasis, the eyeball will move the opposite direction, that too in the upward direction. In apogeotropic kind of BPPV, the deceased or fault ear lies above. What are the manners used for reduction of geotropic nystagmus? These are the following manners, like Limpert's manner generally we use for reduction of geotropic kind of nystagmus. And the steps of Limpert's manner include: ask the patient to lie on the couch in the supine position and turn the head toward the deceased side and stay in this position for 1 minute. After completion of 1 minute, turn the head 180 degrees to the opposite side and stay in this position for 1 minute. After that, patient has to lie down on the prone position with head in flexion after 30 degrees. Stay in this position for at least 1 to 2 minutes. This causes reduction of otoconia from horizontal semicircular canal. This is the picture showing steps of Limpert's manner. What are the manners used for reduction of apogeotropic kind of nystagmus? These three are the manners which are used for reduction of cupulolithiasis. One is Guffonis manner, second is modified Siemens manner, and third one is head shaking. Here our primary target is to detach the debris from the cupula and convert into canalolithiasis. After that, the reduction manners used for canalolithiasis has to be implemented, like Limpert's manner. In Guffonis manner, patient is rapidly moved to the affected side and the head turned to the upwards, like so that nose has to face the ceiling. This diagram clearly shows the steps of Guffonis manner, where the patient lies on the deceased side with the head turning towards the 45 degrees to the opposite side, so that the nose has to face the ceiling. In the modified Siemens manner, rapid movements has to be done to dislodge the cupula debris. And the last one is head shaking method, so that it will convert the cupulolithiasis into canalolithiasis. Thank you. I think this seminar will help you in clinically approaching a complaint like vertigo. Thank you.